I'm one of these perverse characters who's interested in in what other people consider the normal dropouts and losers in the game. I want to find out how we can expand the value of drugs. So I've always been studying drug resistance, and the leopard doesn't change its spots. I'm doing the same thing with immunotherapy, and
How so? How so?
well, several ways. From the beginning, I thought that one should try to do more things to optimize the antigenicity of the tumor. And there were people who were removing tumors, creating vaccines, and re-injecting them. And over the years, that kind of work, starting with the famous Hollingshead experiments in Seattle, it always came close to winning. It was always intriguing, hints of survival benefit, and it didn't quite have the numbers.
Can you explain
And
that just in maybe 1 or 2 minutes what that Seattle experiment was all
they,
about?
they, the best example was probably when they got to the point where they took resected rectal tumors. They would remove them into the lab and they would disrupt the cells and create a vaccine and re-inject the cell-free antigen-rich component back into the patients as an attempt at adjuvant therapy to prevent recurrence of the cancer. And there were a lot of experiments of that type that came close. Hints of activity, some apparent responses, but it never quite made the ideal phase 3 trial criteria. Not surprising, such a heterogeneous group of patients, so many factors involved in immunity. It was probably a good idea applied injudiciously because we just didn't know enough about what was involved. Subsequently, the people at the NIH started removing tumors, mixing them with lymphocytes, and using the tumor antigens to turn the lymphocytes into trained cancer-specific killers. That's still ongoing. Rosenberg's name is most associated with that work, and there are occasional dramatic complete remissions, possible cures of stage 4 disease. The problem, the tumor has to come out. It's a long lab process. You need lymphocytes, you need interleukin, tumor growth factors. It's a very complex, expensive process. And in a way, it's, again, there's something very important going on, but it's not practical or available for most people. So I went back and said, why can't we produce these lab criteria in the patient? The patient has the growth factor, they have the lymphocytes. Maybe there's a way of damaging the tumor in the patient so that the patient's lymphocytes will get the message and go after other cancer cells. And, I've tried to do this by injecting the tumor with interleukin 2, with GM-CSF, and it's very nice. You inject the tumor, it gets inflamed, and often it disappears. And occasionally, the tumors that you didn't inject also disappear. So it's along that theme. The next step, we have better drugs now, and I said, let's use personalized medicine and create chemo cocktails that don't destroy the body's immunity, but damage the tumor sufficiently that the patient's immune system will find an opportunity
Yeah.
to go get the tumor.
I heard about that. I also heard, and maybe, tell me if you've had similar experiences. I've heard from patients who have survived cancer and have gone through chemo that what worked best for them, they would fast for 3 days prior to their chemotherapy, and they would notice that the other patients who didn't do that would experience, all the regular chemo side effects, but they didn't have any. And actually, the chemo was more effective on the tumors, but not on the healthy cells. Is there any science behind this, or is this just anecdotal?
There may be some science, particularly breast cancer and ovarian, endocrine-driven tumors may be very sensitive to body fat and sugar metabolism. The cautionary note is one has to be careful that the fasting isn't too rigorous so that the person becomes dehydrated. Fasting doesn't mean don't drink enough and get enough electrolytes to avoid thrombosis and fainting. So we don't know how to do it, but yes, there are people who do these short diet interventions, emphasis on short, and for now it's anecdotal, but if someone is strong and not losing weight and has the right type of cancer, there may be a role.
Very interesting. Now,
I think so.
How are you utilizing how has personalized medicine changed the way you treat patients today?
Well, uh, what I did originally is I looked at a couple of the different systems of testing tumors to pick the most promising drugs. And that's what I call first generation tumor testing. We took actual live tumors and we looked at what happens when you add single drugs to the test tube. Which drugs inhibited the tumor? And what everyone found quite quickly is they weren't thrilled with the predictive value of the test. But I'm just a little bit stubborn, I'm told. And what I did is I said, let's forget about the tumors that do well routinely with chemotherapy. So I set aside temporarily the most easy to treat tumors where there wasn't that great a need and urgency for personalized medicine. And I went after the most resistant tumors. And what I found was I turned the criteria around 180 degrees. What people had been doing is saying, we are looking for drugs. And this comes back to modern immunotherapy. Mm-hmm. So there is a path here. What I said is, people are looking for drugs that kill 80, 90, 100% of the tumor. And if they don't do that, they say the drug's no good. I said, let's quantitate and see what's happening. And it turned out that a lot of so-called failing drugs produced 10, 20, 30% inhibition at very low, safe doses. And this was being, and is being, totally ignored. Now, my thing, one of them has been biochemical modulation. How do you change the chemistry of a cell so that the drugs will work better? And the next step for me is I would take drugs that didn't work or worked at the 10, 20% level, the throwaways, drugs that had already been used in patients, the patient was progressing, then we biopsied the tumor and we saw that the drug had very low 10, 20% levels of activity. But when we re-partnered these failed drugs, we were suddenly getting 50, 60% inhibition. And occasionally, we were getting 99% inhibition with drugs that we were throwing away. So I went back and I created a whole series of drug cocktails using the low dose concept and the synchrony between the drugs. And we've been able to take drugs that people have failed And the majority of people respond to the drugs when they are recombined. Not the same way in every disease. Different combinations, it's complicated. But, after doing it 1,000 times, it's not that difficult to help the majority with some types of tumors. There are diseases I haven't studied, but, breast, lung, ovary, colon, pancreas. We have a ton of data, stomach. We have a ton of just data that when people see it, that blows their mind.
Mm-hmm.
How these old drugs can have such good activity. And because they're usable in low dose, you can give them more often. And it turns out the analogy everyone likes is the hammer and nail. What I'm doing is tapping the nail every 2 weeks, where other people were trying to slam it in once every 4 weeks. And we can manage to control a lot of tumors safely with 2-week dosage, where 4-week dosage is very toxic, and actually the high doses turn out, when we check them in the lab, to be antagonistic. Why? Everyone's seen it, but we don't know why. So it's probably a completely different mechanism that's going on. People think it's metronomic. But the point is, we can damage tumors very easily with a whole spectrum of drugs. It changes the membrane. It makes them leak antigen. We are creating a type of a vaccine and leaving the immune system intact. So that's been very successful for us.
So
We've done that.
So this vaccine is like a homemade, customized concoction.
Yes, but we don't take the tumor out of the patient. What we're doing is we're treating the tumor, and we are recreating the laboratory changes in the patient. So we're sparing them the invasive step, and we are reconfiguring the cell membrane. We are making it leak antigen. We are creating a lot of DNA damage, which is antigenic. And we've done this now. We have people who've had complete remissions of kidney cancer, cholangiocarcinoma, hepatoma, where they had the chemo before, or they had the immunotherapy, it failed. Then we damaged the tumor, and they showed a strong immune reaction. And there was just a paper published in the Oncologist in June, someone describing one of my cocktails. They didn't know it was one of my cocktails, but it is, And they described people with stomach cancer who had failed immunotherapy going into remission. So, that's very exciting in terms of what we're doing with Hoffman, because it means we can have someone with stomach cancer and we can try the chemo our way before, then give them their vaccine strong tumor into the immunotherapy trial, and we even get, after the immunotherapy trial, another chance to make the immunotherapy work. And by the way, my first patient that I sent for the immunotherapy trial in gastric cancer, who was too old to get chemo, is a lovely responder to the immunotherapy regimen that we're trying.
Interesting.
So gastric, and 10 years ago, I published my cocktail as being very active, and I mentioned last time that about 2 months ago, I had a couple of those old chemo patients that I treated 10 years ago walk into the office 10 years in remission.
Interesting.
So, everything says to me that there's going to be synergy between the chemo and the immuno. And the newest thing that's going on now is, I'm interested in host factors, and we've been looking at our survival data, and this summer I had a student go over our colon cancer experience, and she found the same thing we reported in JAMA years ago for stomach cancer, that people with high white counts or high platelet counts did terribly. And so I am looking into it now, and what we're finding in the literature is that high platelet counts probably antagonize immunotherapy and chemo as well. And so what I'm hoping to do is isolate out these higher risk patients and get rid of those high platelet counts by hook or by crook. And there are several published candidate methods, and to make them more amenable to immunotherapy. And for some of these people, the answer may be as simple as a souped up aspirin regimen.
Wow. Now, how does, let's say a patient is newly diagnosed and maybe they don't have the fortune of you being their oncologist. So,
well, we have to fix that.
But what do you recommend they do? Let's say you've been diagnosed. I mean, do you just trust the first oncologist's advice that you talk to? How can patients get just a little more educated on the latest options that are available for them? Because not everyone's as progressive as you when it comes to these forward-thinking kind of treatments.
Very difficult question. The whole area of informed consent for people who study communication between doctors and patients turns out to be very, very complicated. The seminal observation from my point of view is the ideal experimental setting in which patients go into a room with a trained doctor who has a script of supposedly ideal information to give the patient. And there are 3 people, or whatever number, monitoring the interview through a one-way mirror or whatever. And the doctor does a perfect job talking to the patient. The next day, someone interviews the patient on the material that was presented in the interview. The majority of people missed critical information. It's not that the doctors aren't doing a good job, although that can happen also, because I think I mentioned in one of our previous conversations, all these cancer areas have become super complicated. You know, there can be 1,000 papers a year coming out on colon cancer or stomach cancer. And there are very few people who are looking at more than the 10 or 20 that someone had a vested interest in publicizing. It's getting very hard to stay on top of all the good science, the preclinical that's out there.
Now, how quickly are these things moving? Like, I mean...
That's also a problem. A good observation or a clinical trial used to take 2 years to get into print. Now, people are worried about insider trading, and it can take 3 years. And when they report, they're not talking to the patients or the doctors. They're reporting so that the FDA and the Trade Commission isn't going to sanction them. So people are becoming super neutral in how they present exciting material. And how one parses that and gets help is increasingly a problem. But part of the answer is no one should go to a doctor to discuss cancer therapy without bringing a fairly sophisticated, objective person with them. Preferably 2 of them, not 1.
I see.
And it's not good enough to have your dear old aunt, if she's a 70-year-old high school graduate, be the person coming along. It may be, you know, the ladies who get to be 70 have a lot of survival skills. I don't want to sell them short, but when it comes to statistics, terminology, biology, they may not be the best choice. And people who don't have the background need to bring someone along who's not nervous. The other thing is people have to ask the question that the doctor is afraid of and that the patient is afraid of. What people are doing is saying, how long do I have to live? And the doctor says it's metastatic disease, 6 months, 9 months. That is a signal to go see a second opinion. That is just not a sophisticated answer. That was true when they were in your doctor was in medical school 10 and 20 years ago. This 6 months to live generalization doesn't serve. That's a signal. What else is out there?
Mm-hmm.
That's not to say that what they're going to recommend isn't something good or even the right thing. And when it's a 6-month median, there are people who live years with that regimen. But those are the people who should be looking for less toxic treatments, more promising, researchy things that don't preclude, and this is to me important, don't preclude the best standard, but be able to give yourself the bells and whistle of promising science.
Hmm.
It's that balance that one needs. And easier said than done, but it's not impossible for anyone can do it with a life coach.
Interesting. Yeah, I mean, there's so much that we can unpack just on this topic alone, but we will save more for future interviews. Dr. Bruckner from Bruckner Oncology in the Bronx, New York. He also does clinical research studies, so he's on the forefront of some of these new ideas and new paradigms in oncology. So,
Did I mention that we just finished analyzing our pancreatic cancer vitamin C adjunct study and confirmed that we practically eliminated severe side effects, including blood clots and a neuropathy. So we've done very well on the safety front.
what was the vitamin C dosage?
It was the high dose, 75 to 100 grams,
Wow. Okay.
which is very well tolerated.
Mm-hmm. It was a one-time administration?
No, it was once or twice a week.
Okay. Fascinating. Yeah, so all these things are starting to come together. I mean, how close are we to taking a quantum leap in treating cancer?
And I'm most excited that it had some effect on clotting, because clotting is platelets, and as we started, high platelets may be an area that we can target to improve drug sensitivity.
Interesting. So just some people are naturally produce more platelets than others, or does the cancer have something to do with that?
The cancer, the cancer may have something to do with it.
Interesting. Well, fascinating. I mean, we definitely need to continue these discussions, but we will unpack all the nuggets from this interview and create some short videos as well as this interview in its entirety on Bruckner Oncology. So thank you very much, Dr. Bruckner, for your time. If somebody wants to connect with you, where can they reach you? I know we'll have links to your website, but where else can they reach you?
Oh, it's Bruckner Oncology at gmail.com.
Okay, we will put the links underneath the video. Thank you very much for your time. Again, Happy New Year to you, and
Thank you.
we'll be in touch soon. Maybe in
Nice,
another.
nice to pick up these conversations.
Yeah, it was fun, very interesting, and maybe 2 to 4 weeks we'll do another one and see how things are progressing.
Thank you.
Thank you very much.
Have a nice weekend.
You too. Thank you.